Now, for those new families in the audience, and I noticed a couple of times on the slides you just showed us, please remember that you will hear a lot about Prader-Willi syndrome today and a lot of complications, but each person is an individual. They'll develop at their own pace, and they won't, many of them will only have a few of the characteristics. So please don't take it all to heart at this early stage of finding out about Prader-Willi syndrome. I now call Dr. Deepan Singh up to the microphone. Dr. Deepan Singh is a board-certified child, adolescent and adult psychiatrist who has developed a strong interest and expertise in the management of Prader-Willi syndrome. Dr. Singh served as the Vice Chair of the Ambulatory Services and Chief of Research and Grants at Main Mindos Medical Center in Brooklyn, New York. He has numerous peer-reviewed publications and presentations on behalf of aspects of Prader-Willi syndrome. As an active clinical and scientific researcher, he serves on the Scientific Review Board of PWS USA and is a founding member. I may have just promoted you there, I'm not sure. He also serves on the Foundation of Prader-Willi Syndrome Research. He's also on Tony's IPSWO Mental Health Network. Dr. Singh's recent work is a book, Neurobehavioral Manifestations of Prader-Willi Syndrome, a guide for clinicians and caregivers, which is an easy read and is a great source for all clinicians and caregivers. And we urge you to seek that book out. To speak on mental health and behaviours, please welcome Dr. Deepan Singh.
Thank you so much. I'm gonna use this because I think that way I won't have to move 2 slides. All right. Okay. Thank you all for joining. I'm so glad to see that there's been a good turnout. I'm gonna move a lot, so but I'll try not to be too blurry. Okay. So. Before I go ahead, Dr. Tuang, thank you so much. And can I request you to please try to organize the next Asia-Pacific meeting in Thailand? That would be really cool. Yeah, right? Who wants to go to Thailand, right? There you go. Okay, whatever I can do to help with that, yeah. So I have several grants from FPWR. I do some consultation for drug companies listed here. I do get some royalties. It's much smaller than you can imagine for the book, but you know, it's been really heartwarming to hear from all of you and so many people who've read the book and they've come up to me. I get emails from all over the world, you know, thanking me for the book. And trust me, when I was writing it, I had a lot of imposter syndrome. You know, there was very little out there, and I was like, am I the person who should be writing this book? And it took a lot of encouragement from my patients, from my family, and thank you for reading my book. And please send your feedback if there's something I can do to improve for the future. If there's something that's blatantly wrong, just send me an email only to me. I'm just kidding. All right. So all of you have seen this. Who's seen this before, this slide? All right, so this is a very well-informed group of people. I might not need to finish this talk. But I want to highlight that, you know, most of the things mentioned here, right, are related to behavioral problems, right? As our patients, so it's a really good problem to have, in fact, that we can now focus on the behavioral issues in PWS. The fact of the matter is that the obesity, the morbid obesity, and the medical complications thereof in the past meant that patients were not living long enough. They were not there were other fires to put out. Okay, and now the patients are living longer, they're with us longer. We have more time with them, right? And we can see a lot more behavioral issues. So, our success means that we need to work harder to make their life better as they grow older. So this is just like a schematic to give you a sense of, what the genes are doing to our brains and how that's leading to behavioral manifestations, right? So just to highlight some of the genes, right, the MAGEL2 has been linked with more of the autism features. The Nectin has been linked with skin picking. SNORD115, 116 is controversial, so I won't go into that too much. And then in addition to the hypothalamus that we all know about as being affected and leading to hormonal dysfunction, we have a lot of gray and white matter brain changes that lead to the behavioral manifestations. And also the neurotransmitters, right? So the molecules that send messages from one part of the body to the other, one part of the brain to the other, they are also dysfunctional. So I want to talk about a basic function of our brain, right? So our brains are prediction machines. That's basically what its function is, right? If I see this, I have to react that way. And all animals have brains for the same purpose: what to do next based on what's happening in my environment right now. The brain helps predict what to do next, right? And helps us move towards that, right? So that requires, in an advanced brain, like human brains, there's a lot of information that we need to take in, and then we need to assess that information, and then we need to respond accordingly. So for example, if you have plans to go to Manly Beach, like I do, right, this afternoon, and you put your sunscreen on and everything else, you're ready, and you want to go into the water, and you dip your toe in, and it's minus 15 degrees, okay? And then you're like, oh my goodness, looks beautiful, but I'm going to freeze to death. Now you have to accept that as fact, right? And either jump in with the sharks or just enjoy the sand on the outside, right? So your brain is the one that's making the decision, right? Your brain is taking all that information in, and you're having to adjust, right? So the capacity to flexibly adapt to our ever-changing environment is response monitoring. So we take into account uncertainty based on our extrinsic stimuli, right? So, cold. Intrinsic stimuli, my stomach turned, how cold that was, right? And whatever was happening internally as well as externally. And we take that information, and we have some sort of like intrinsic, sort of like intuitive responses. We jerk back, right? And then some thought of responses. Okay, what's going to happen next if I jump into the water? So some things which are very impulsive that would happen right away, and some things that we'll plan about and then change our actions accordingly. So that's response monitoring. And then we make a decision, right? So that's how we are supposed to function. If it doesn't work well, as is the issue with Prader-Willi syndrome, and you can say, so in the cortex, which is the higher functioning part of the brains, our prefrontal cortex, our orbitofrontal cortex, our insular cortex, the anterior cingulate cortex, these are some of the areas of the brain. They're not very well functioning in Prader-Willi syndrome. It's not like they're not functioning, right? They're not, it's not like they have no higher function at all. That's not the case. All right, and there's a lot of variability, as you can tell by looking at your loved ones with PWS and spending time with them. Not everyone is the same, right? But their ability often is deficient, dysfunctional, right? And what that leads to is that since they're not able to monitor and respond adaptively, it can lead to anxious. So same situation, you have a plan to go with your loved one to PWS to Manly Beach, right? You dip your toe in, you freak out, it's like, no, we're gonna freeze to death, we're staying outside, and I already see some shark fins, all right? But your child with PWS has been planning to go into that, jump in, no matter what, sharks or not, for the last 3 months. They've been asking you incessantly 35 times a day. Okay? So they're going to, so this leads to things like getting stuck, right? They can get impulsive and aggressive. They can feel extremely anxious. And they can, sometimes make up stories about you next day in school and say, my mom is abusing me, and sometimes it's true, so I don't want to make fun of that, but sometimes, I was being facetious with that particular example, but that has happened, right? Where people have, confabulated, right? When they're upset about something else. And then excoriation is somehow, I don't think it's exactly linked to it, but I think when in moments of stress, they go towards things which are self-soothing mechanisms for them, right? So it's almost like grooming and stuff. Just like when we are nervous, we can touch our hair or, sort of crack our knuckles, annoying habits that our wives, get upset with us for. So they can skin pick like that, right? So, and response perseveration is an interesting concept that has, unfortunately, I haven't written about it in publications yet, and I think I should. I'm working on that. But it's the inappropriate repetition of particular response despite the absence or cessation of reward. So you have chosen not to go into the water, but they are just hounding you, right? And they can see, so in someone else without PWS, when they see you getting upset or even crying, tears in your eyes or grimacing, the child might back off, right? Because it's aversive to them. But in someone with PWS, despite what they're seeing in the environment, their discomfort is so high for them that they'll keep jumping at it like Donald Duck, even if it's hurting them. Okay? And very often I've, just as a practical implication in your day-to-day life, when your loved one, if you see a pattern, right? So I had a patient who would always have a meltdown after taking walks, right before he entered the door, with his mom, right? So they would go on nice, wonderful walks, everything's fine, and right before they would enter the house, he would have a meltdown. And what I asked mom to do is to spend some time outside before they, enter the house, and allow him to go in first through the back door, and she enters later. And that broke that cycle. So what I'm trying to say is that they get into this habit loop, and everything needs to go exactly the way it was, right? And if that cycle includes a meltdown, that meltdown will happen unless you modify that cycle. Okay? So that's response perseveration. And it looks like anxiety, and it is impulsivity, right? But response perseveration gives you a fuller sense. Please, how much time do I have left? Anyone keeping time? 15. Okay, I have time. Okay. All right, so we have psychiatric comorbidities, some developmental features, behavioral features. All of you are familiar with hyperphagia. There was a very interesting question that was asked. I'll try to answer that now. I think the question was whether, whether there's some trauma associated with hyperphagia and how folks with Prader-Willi syndrome process it. So and I spoke a little bit about it yesterday, if you attended the dinner. One of the biggest and unfortunate, current issue with PWS is that we don't have a lot of self-report on the experience of hyperphagia amongst folks with PWS, right? So very recently I started thinking about the patient's experience of hyperphagia, right? Because by the time we are seeing hyperphagia, we are seeing food-seeking behaviors, right? That's already beyond the thought state, right? So they must be experiencing the hyperphagia perhaps for longer than when the hyperphagia becomes visible to us. So very recently, just a few weeks ago, I had, I asked one of my 10-year-old patients, do you feel, it was a leading question, so I need to, so like, how hungry do you feel? Do you feel hungry all day long? Do you feel, and this is not a question that had ever been asked of him, right? We had asked the parents, including me, I had asked the parents, are you needing to lock the pantry? Is there any food stealing? Is there any food sneaking? But when I asked the patient, it was very revelatory when he said, I feel hungry all the time, and I have to stop myself all the time. And that open conversation allows us to, with the patient's consent, even before the parents have decided to lock doors, the patient might say, you know what, yeah, I will feel better if you lock the pantry. And that's, I think, that engages them more and it's helpful. Okay, so intellectual, issues can be there. Autism spectrum symptoms. Many patients and their parents. Many parents are very upset about having a dual diagnosis of autism. But in many, at least in the United States, if you see autism, you diagnose autism, you get the services that come with autism. Remember, autism is a lot more common than Prader-Willi syndrome, right? So there are a lot more services for autism than for Prader-Willi syndrome, and you should take advantage of that. Obsessive compulsive symptoms are present. ADHD is a lot more common than people recognize or treat. Again, people just try to lump everything within PWS. If someone has ADHD and they have PWS, many doctors will just call it, oh, it's all because of PWS. It might be, but there's no treatment for PWS, whereas there is treatment for ADHD. So it's important to diagnose all the comorbidities and treat them accordingly. Mood disorder, depression is more common among the more, the patients with higher IQ. Right, they can see the differences between themselves and others, right? And they are frustrated about, that difference, and that can lead to depression. And this is one of the reasons why involvement in a community like this at a very early stage and a young age for patients is very beneficial. That's why I strongly advocate for parents to not keep the diagnosis from their children, because they can become part of this community. They don't feel alone. They know that, they don't blame themselves or their families for their mental health issues, or for their, differences. I'll talk more about psychosis given the time, and it's sort of this mishmash between a mood condition and a psychotic condition, and it's called cycloid psychosis. And you can see that I haven't mentioned anxiety anywhere here, whereas if I asked you what's the most common issue with your loved one, you'll say, oh, anxiety, right? But anxiety is more of a the anxiety state, not an anxiety disorder. It's very hard to diagnose like generalized anxiety disorder or panic disorder or anything like that in folks with PWS. They present in an anxious state, but the underlying cause could be a lot of these other things. Okay, so I'm skipping over. My domain is not behavioral therapy. So I'm assuming that you've gone through the steps, right? You have a good diagnosis. You have tried. You're getting all the resources. When it comes to services from the government or from school. And your child has been on some sort of behavioral therapy. You've tried it at least for a couple of months. things have not helped, now you're thinking about medication, all right? And again, think about medication like any other human-made technology, right? Like the wheels on your suitcase, right? Or your refrigerator, or the light or the microphone, right? People lump all medications as one thing. Oh, medicines did not work for my child. It's like saying that you were trying to, go from this hotel to Manly Beach, but you tried to get there on a refrigerator, right? And then the refrigerator did not take you there, and you say, oh, all technology is bad for me. I'm not going to use any technology. It's the same thing, guys, all right? Medication is human-made technology for your benefit and the benefit of your children, all right? Please remove the stigma against medication from your mind, okay? All right. All right, so this is a busy slide. I'll go through it one by one. Okay, so let's talk about irritability, aggression. Now we know that there's something called response perseveration, there's impulsivity, there's a reactive aggression. They are not bad kids, not bad people. If they threw a chair at you, it's because at that moment they couldn't stop themselves and there was no other option that they could imagine. And that's why they cry and they say sorry afterwards. All right? They're not malicious, they're not Bernie Madoffs, they're not going to go, coldly slice your tires just because they're pissed off with you 2 days later, right? So irritability, aggression could be episodic or chronic, right? So if your child doesn't have aggression at all, and all of a sudden has this, periods where there's a lot of aggression coming up, then that's episodic, aggression, and that could be, you want to make sure there isn't, psychosis, depression, other symptoms, because the treatment is completely different, right? You need to use antipsychotics or mood-stabilizing medicines or antidepressants. Whereas if there's chronic aggression, right, so they have a short fuse all the time and you're walking on eggshells all the time, then often you might benefit from alpha agonists, which is like guanfacine, the medicine that I spoke about yesterday. There is, I have cautiously but successfully started using sertraline quite a bit. Low dose, remember low dosages, starting at 12.5 milligrams and going up to 50 milligrams. And 50 milligrams would be a starting dose for you or me for depression and anxiety, but that would be kind of the upper range of the dose in folks with PWS, okay? ADHD, again, very common. It depends. The treatment would, differ based on whether or not the individual has a lot of excessive daytime sleepiness. So if there's excessive daytime sleepiness and skin picking and tics, skin picking, or if there's a lot of skin picking behavior, stimulant medications can be hard to use because they can make the picking behavior worse. So alpha agonists, again, these are medicines like Intuniv, which is guanfacine extended release, or clonidine extended release. So not Catapress, the short acting, because it's too sleep inducing, but the longer acting one, which I don't know if that's available in Australia. It comes by the name of Capvay, clonidine extended release in the US. But guanfacine, and somebody asked, whether it's okay to combine guanfacine with stimulants, and it is. It's very commonly done, and also modafinil, right? So again, use the technology available to you. So if your child has has a lot of skin picking and guanfacine worked wonderfully, but they're very sleepy with it, think about modafinil. It's okay, all right? And if there's no excessive daytime sleepiness, it's a no-brainer. Go straight to guanfacine, okay? Light therapy might have a role in excessive daytime sleep. I'm studying that right now, so more to come. Hopefully in a future conference you'll hear more on that. As long as it's good quality, full spectrum, large lamp devices, using them for 2 hours a day might have benefit. I've seen some anecdotal evidence already, but more to come on a double-blind study that we are doing. Picking behaviors, right? NAC is sort of like the first line, I would say, because it's over the counter. You don't even have to go to a psychiatrist or your pediatrician for it. But people really underdose it, okay? So I would say starting it at like 600 milligrams twice a day, and then not hesitating to go up. If you're really going up very high, like more than 1,200 or 1,800 twice, I mean, I go as high as 2,400 3 times a day, but I would not recommend that because there are a few case reports of people having that psychotic, getting mood activated with very high dosages of NAC. The only side effect with the NAC is that it can cause GI upset a little bit. I don't recommend it in people who have cancers or at very high risk for cancers because it's a very strong antioxidant. So if you have any family or friends who has suffered from cancer, you would know that they have to stop all their vitamins because the vitamins can make cells grow. So you have to avoid NAC in anyone who's at very high risk of cancers. Usually folks with PWS are not. Topiramate and naltrexone has some evidence. If the NAC doesn't work, my first recommendation would again be guanfacine before you try anything else. Topiramate and naltrexone have been shown to cause weight loss, but okay, misspelling there, but not the naltrexone as much in PWS. By the way, topiramate is the biggest secret in PWS. So topiramate is the only medicine which has a double-blind placebo-controlled trial which has shown a reduction in hyperphagia. And why people don't prescribe topiramate more is beyond my comprehension. So if your child has hyperphagia and you're waiting for DCCR, you're waiting for 2,500 other drugs to come in, you don't have to wait that long. At least give them the advantage of topiramate now while these other drugs come down the pipeline. Okay. I don't think we have a lot of time. Now, if your child has ever had psychosis, that doesn't mean that they have schizophrenia. Okay? It does not mean that. Most patients with Prader-Willi syndrome don't have they have episodic short bursts of psychosis, which is very troubling and very disabling, but it's really, responds very quickly to medication and people do get better. And it's a little different from other psychotic behaviors. There's confusion, there could be voice hearing experience, paranoia, but it responds very well and very rapidly to treatment. I've written a paper on that, and it's available online if you are interested. So if there are manic symptoms or psychotic symptoms, I don't think there's a choice but to go to an antipsychotic as soon as possible, okay? And sometimes hospitalization is needed, but many of my patients, they don't do very well in hospitals, so we are able to, if you have a capable psychiatrist, you might be able to manage without hospitalization. All right, so guanfacine, I spoke a lot about yesterday, so I'm not going to bore you again. If you guys have seen it, it works, it's effective against a lot of things in PWS, hyperactivity symptoms, non-compliance, aggressive behavior, skin picking, rectal picking, and fatigue is the only issue. I can talk more about that in the future, but it's not as bad as people make it out to be, the fatigue, and it gets better with time. We're looking at new treatments. I spoke about the light therapy already, and then we're working on a large VNS study, vagal nerve stimulation study. So more to come on that. Stay tuned, and thank you for your attention.
Thank you so much. I suspect we're out of time for questions, but I've certainly learnt a lot about Manly and swimming on the beach. No, seriously, a very informative talk about the complexities of the brain. And thank you so much for coming all this way to give that